This is the topic that I was asked to address, and the question I gave myself is this just of historical interest? Because actually most of the trials were done quite a long time ago, or is there issues that are relevant today? These are my disclosures, but I have no conflicts with regard to this presentation. And you've heard yesterday that we have very carefully defined the long-term outcomes in populations, for example, with non-STEMI, and you can see here the 5-year death rates of about 20%. So that is very considerable. And that many of these events occur after hospital discharge. And here you can see the patients who present initially with ST depression. Many of those are non-STEMIs, and they, over the course in this landmark analysis, have an accumulating risk of events over the longer term, which actually exceeds those of the survivors of STEMI. And that's the independent prediction. So, you could then ask, well, what about the most recent information from large-scale studies? And these are large-scale observational studies of more than 150,000 patients. So this is the US, the MINAP program in the UK, you know the national registries in Sweden, and also a large program in France. And the result is the same. 1 in 5 patients who suffered an MI or stroke or cardiovascular death in the first year after MI. And for patients that are diabetic or patients with a prior MI, the risks are much higher. So, although our data was a little bit older, this is current. This is 2015 data. And then you ask the question, okay, so that's observational data. There are many frail patients. What about if you took a really well-treated population in a trial? And the TIMI group are very experienced at trials, and this is daraplaudib, and daraplaudib was trying to test LP-PLA2, but actually the intervention did nothing. The yellow line and the blue line are superimposed. But that isn't the reason that I'm presenting this. The reason that I'm presenting this is that the 36-month event rate of cardiovascular death, MI, and stroke in this very well-treated population is 15%. So those of you who say, well, in my practice it is 3%, 2%, I challenge you to look very carefully and comprehensively. Because actually in the real world, and even in very well-treated patients, it may be higher than we think. Now, going back to the original RITA-3 study, and amazingly, this is from 2002, so it's a long time ago. We asked a very simple question. And we asked a question at the time when the UK was a very conservative country as far as intervention goes. We said, if this is a trial that was funded by our British Heart Foundation, and I was the PI of this trial, and the question was, if we routinely undertook angiography followed by revascularization, and that could be PCI or CABG, would that give a better longer-term outcome than the conservative strategy, which is the intervention being driven by ischemia or provoked ischemia? And the answer is there was a very clear difference in favor of intervention. And you can see that was not just an impact on refractory angina, there was an impact on deaths, and you can see on cardiovascular deaths, at 5 years, there is a sustained impact. And that's really remarkable, because here's a strategy done at time 0, and 5 years later, there is still a difference, despite the fact in the conservative arm, there are crossovers. So this is intention to treat, and it's despite that, 5 years later. At this last ESC Congress, my colleagues presented the 10-year outcomes of this study, and over 10 years, it is not a surprise that the curves move back together. But that's all the other contributors to long-term death. Now, does everybody benefit the same or not? So with Stuart Pocock and Tim Clayton, we analyzed the risk groups in the RITA trial, and the risk groups are shown here. We divided the population into different risk characteristics, and these are obviously the high-risk groups in the conservative arm, and they have a much higher event rate. And this is the same groups in the intervention arm. So there's a big difference. And the biggest difference here is in the high-risk population. That's the biggest delta. There's also a difference in angina, a reduction in angina during follow-up in 4 months, a year, and beyond. We weren't the only trial to demonstrate this. RITA-3 was the first trial to have 5-year long-term outcomes. It conducted almost the same time was the FRISC-2 Scandinavian trial, very well conducted trial, and it showed exactly the same result. It showed that the invasive strategy was better than the non-invasive strategy. It showed they divided their population into risk groups, and it showed that there was the biggest separation in the high-risk patients. So the most to benefit in the high-risk patients. And that's the medium risk, and then the lower risk. So that the absolute risk reductions are greatest in the high-risk group. And FRISC-2 showed 5-year outcomes which were sustained, just as we did in RITA-3. There was one other trial conducted at that time, which was the American Tactics trial. Unfortunately, they chose to only have 6-month outcomes, so they have no long-term data. There was an additional trial from the Netherlands, and this is the ICTIS trial. Now, the ICTIS trial showed a different result. This is all-cause mortality, which was not different. And in terms of MI, the ICTIS trial showed more MIs in the intervention arm. Hang on, how did they measure it? They did routine troponin assays after the intervention. And actually, we now know that the minor troponin elevations after MI do not carry the same prognostic significance as spontaneous elevations. So, in reflection, it was a function of the design of the trial. And this is the composite of all of the trials of invasive and conservative therapy, and the result, in my view, is conclusive. A hazard ratio, an odds ratio of 0.84 in favor of the interventional strategy. Now, what about older trials and newer trials? You can see that the older trials were non-significant. There were some issues that were not relevant to modern intervention. In terms of the troponin data, you can see that in those that had troponin elevations to start with, there was more benefit. Any marker positive was more benefit. And so what we did is we said, right, the 3 main groups, our group in the UK for RITA-3, the FRISC-2 group in Scandinavia, and the ICTIS group, we collaborated. And we each shared all of the data from every patient, the independent data. And we ran the analysis simultaneously in the 3 countries. So this is independent analysis, patient level. And it produced exactly the same result. You can see that this is actually from the European guideline, and this shows you that the benefit in terms of risk reduction is not trivial. This is not relative risk reduction. This is absolute risk reduction of 11% in the high-risk group, 3.8% of the medium risk, and 2% in the low risk. So it's remarkable that a strategy can have a 5-year outcome with still an absolute 11% difference 5 years later. So is that the end of the story? Actually, it isn't. Let's consider the issues that are relevant to today's practice. So we asked in our large GRACE program, does the risk predictors that we've derived in the GRACE risk score, does it predict in-hospital death? And no surprise, yes it does. There's a highly powerful relationship with a high-risk group having the increased rate of in-hospital death. Does it predict in-hospital cath? Oops. Yes, it does. But it's the other way around. So we've got a strong predictor that actually most of the people who get cath are low risk. So actually we have a risk treatment paradox. And revascularization shows the same paradox. So actually it's the low-risk people who are getting most of the interventions, and we are scared to do the interventions in some of the higher-risk people. So some of my colleagues said, well, but this makes sense. Many of these high-risk people, it's not feasible to do the interventions in them. Well, is that true? We first of all retested this in Canada. So with Sean Goodman and Andrew Yan and colleagues, we tested exactly the same thing of the application of the GRACE risk score, and we asked clinicians whether they thought they were intervening on high risk, and they weren't. It was exactly the same risk treatment paradox. And what's more, the Canadians excluded the very elderly. They excluded the people with renal dysfunction in case that was driving the result. It was exactly the same result. So they found that after adjustment, excluding over 75, excluding renal function, excluding early deaths, they had a similar pattern of this risk treatment paradox. Now here's what's interesting. We asked, simply on the basis of the current practice, if you took hospitals that by design were performing the highest third in the rate of intervention, and you compared them with matched patients from hospitals that were conservative, would there be a difference in outcome? Because this is the rate of PCI in the high intervention hospitals, and you can see that it's highest in the low risk group, 77%, 69%, 51%. But if you take the conservative hospitals, it's right down there. So these are the same patients. This is just a difference in practice. And we've analyzed this, and we published this in BMJ Open in 2014. And if we simply take from the composite of the randomized trials the benefits that were observed in practice and apply it to this difference, we could save 30 to 80 cardiovascular deaths and MIs per 10,000 patients. So this is simply a difference in practice, which is feasible. It isn't hypothetical, because it's what was actually happening. Does the timing matter? Well, the time ACS, we collaborated with Shamir Mehta and applied the GRACE risk score. The time ACS trial as a whole did not show a clear benefit for more rapid intervention in non-STEMIs. However, if you look very carefully, you'll see that by design, we characterized the population in high risk and low to intermediate risk, and all the benefit was in the high risk between the early and the delayed strategy. Yes. We know that in the European guidelines, The validation of the diagnosis is important in response to anti-anginal treatment, the routine biochemistry, ST monitoring, risk score assessment, etc. So what's happening in practice? In practice, there's been considerable change. And, you know, we can improve this further, but this is the secondary prevention not for a selected cohort. This is for every patient in our country. This is 750,000 records. So this is every elderly, every frail patient, including all the others. And it's the rate of ACE, ARB, aspirin, beta blockers, at that time clopidogrel, and statins over the course of that time. And the UK changed from being a low intervention country to a higher intervention country. And you can see that this is the change following these intervention trials, going from 35% up to 71% in the 2010s. And just for comparison, I show you that there was a radical change in terms of thrombolysis versus primary PCI. This is, again, the whole country. This isn't a selected population. It's been a revolution in turning from thrombolysis to primary PCI. And the UK was slow. They were a conservative group compared to many other countries like France, Germany, Czech Republic. What about the timing? We had a question about timing. So these are the timings for the whole country, for all of the intervention centers. And you can see that if you present directly to a hospital that has intervention strategy available, then over the course of time, by 2010, 87% had call to balloon within 150 minutes. So call is when the patient lifts the phone to when the balloon opens the artery. And door to balloon, 88% were within 90 minutes. The problem is in-hospital transfers. So what we've done in the southeastern region of Scotland is to bypass all the small hospitals, have telemetry from the ambulance so the patient comes bypassing the hospitals, bypassing the emergency department. So that for 2015, our call to balloon time is 88 minutes. And it's possible to do it despite the snow that we get in our country. And there's a second element, which is quality improvement. And the quality improvement is being transparent about our results. So in our country, not only do the cardiac surgeons publish their individual data, but here are the intervention centers with the funnel plot. And the funnel plot shows the 95% confidence bounds. And some centers obviously may be in remote locations, so there may be reasons. But if a center is falling outside this, then clearly there is professional investigation as to why that is the case. And the consequence is that the mortality for all the patients is progressively falling. So how can we put all this together? From all of the trials put together, a routine invasive strategy reduces MI and reduces death. Remarkably, this reduction is sustained 5 years later. There is improved angina and quality of life. There is most benefit in high-risk patients, and there is also benefit in moderate and lower risk. But this risk-treatment paradox exists. And if we simply adopted an invasive strategy for these non-STEMIs, we could save an additional 30 to 80 lives per 10,000 patients with our existing resources. Thank you very much.